This is Chapter 8, Disability, Ableism, and Ageism. So to begin with, we have a definition from the textbook. A disability is a disqualification, restriction, or disadvantage, or a limitation in the ability to pursue an occupation because of a physical or mental impairment. So something to keep in mind here is that the definition of disability is going to vary depending on the service that you're looking at the definition from the point of view. So depending on legislation, the individual, an entity, an agency, so whoever's using the term is going to define it differently. And we'll get into some of those details in a minute. So different societies from around the world seemingly tend to group together individuals with specific types of disability. So for example, blindness, paralysis, that kind of thing, and respond to these groups differently depending on the culture and social interpretations associated with the disability in question. So something else to keep in mind is how, for example, the American culture is going to define disability as a whole and how they're going to group different people with different types of disability. And this is going to enter into our personal biases, so reflecting on that as well. Okay, so disability defined, we have 4 commonly recognized definitions. So the first one is from the Social Security Administration. So they define disability as being due to any medically determined physical or mental impairment, specifically diagnosed by a qualified medical provider, and must constitute a total disability. So it's really important that you guys have some type of understanding of these 4 definitions, these 4 groups, because it will come up in your therapy sessions and with working with other clients as well. And if you have an idea, then once again, you're not relying on your client to educate you fully. So if you have an idea, then you can do the research on your own to get more of an understanding in order to help your client, because a lot of this stuff is going to come up with that advocacy piece of working with your clients. So they might have some of the pieces, but you might need to help them out with paperwork, that kind of thing, for filing for disability, finding a resource to get a psychological evaluation so that they can get disability, that kind of thing, services, that stuff. Okay, so there are 2 national benefits programs within Social Security Administration. The first is Social Security Disability Insurance, SSDI, and another thing to keep in mind is that you may hear your clients kind of throwing around these letters, and it might seem kind of confusing. So once again, having some understanding of what this stuff stands for. So SSDI is eligible individuals who have a previous work history and have paid into the system. So they've paid taxes. And then they have an inability to work at a job that they previously held, that they previously had, or an inability to adjust to work in a new job. So maybe an accident, that kind of thing, and then the individual is receiving SSDI. So the next one is supplemental security income, and this is SSI. And this defines a disability not by its effect on one's ability to perform work, but rather by the individual's income, assets, and net worth. So there is a difference between the 2. The next one is the Americans with Disabilities Act. So this is ADA. So disability is a physical or mental impairment that substantially limits one or more major activities. So that's their definition. So physical or mental impairment includes any physiological disorder or condition. This could be a cosmetic disfigurement or an anatomical loss affecting one or more body systems, or any mental or physiological disorder, mental or psychological disorder. So you'll hear about this a lot as well. Major life activity includes those necessary daily activities such as caring for oneself, preparing manual tasks, seeing, hearing, speaking, breathing, learning and working, sitting, standing, walking, lifting, and reaching, which an individual without a significant impairment generally can perform with little or no difficulty. So individuals who have difficulty with these types of tasks. The third one is Individuals with Disabilities Education Improvement Act, so IDEA. So for school-age children, disability is defined as a physical or mental impairment that adversely affects a child's educational performance. And then the last one is the State Vocational Rehabilitation program, so VR. So here they define a disability as a physical or mental impairment that cannot be acute or of an emergency nature, and that must be stable or slowly progressive. So there are many types of disability that a counselor may encounter. Some types of disabilities or disabling conditions that they might encounter are like blindness or vision impairment, deafness or hearing impairment, developmental delay in one or more areas of physical, cognitive, communicative, or social, emotional, and or adaptive. So when you think of like social, emotional, you might think of autism spectrum disorder, that kind of thing. Severe medical conditions, so this could be heart or cardiovascular disease, diabetes, sickle cell anemia, HIV/AIDS, gastrointestinal difficulties, or respiratory or pulmonary disease. Intellectual disability, so that might come up. Neurological impairments such as epilepsy and severe peripheral neuropathy. Orthopedic or musculoskeletal impairment caused by congenital problems, trauma, disease, or other conditions, psychiatric or mental health impairment or mental illness, so serious mental illness, that kind of thing. Traumatic brain injury that causes cognitive and learning or memory disability, as well as dementias, that kind of thing. That comes up a lot if you work with geriatric populations. Okay, so some statistics. The U.S. Census Bureau, this is 2012, so it's a bit dated like most of the information from the book. So they reported that more than 56 million people, so that's 18.7% of the population, have a disability in the United States. 30 million people with a disability are reported to be between the ages of 21 and 64 years old. And this is the age range that's considered working age, so it's something to keep in mind. Approximately 4 million children ages 6 to 14 have a disability, and approximately 50% of people over the age of 65 and 72% of people aged 80 and older have a disability. And then 19.9% of U.S. females and 16.9% of U.S. males have a disability. Statistics don't include soldiers injured or people with disabilities who have been institutionalized. So this would be like nursing homes, mental health facilities, psychiatric hospitals, that kind of thing. So the number of people living with some type of disability might actually be higher than these statistics. There's a pretty good chance that you may have a patient who has a disability. So there are 4 broad models of disabilities. There's the biomedical, functional, environmental, and socio-political models, which is also called the social model. So the biomedical model, here we see disability and illness occurring as the result of a physical or mental condition. So the idea here is that the disability can be cured or managed with healthcare and related services. The focus here is on medical procedures, surgeries, diagnostic tests, therapies, and assertive or adaptive devices. So it's a medical issue that can be treated by the medical field. This is often criticized for focusing on what is wrong, so it's more pathological, and the resultant need to fix the individual. So we as therapists don't tend to adhere to the biomedical model as much. And even within mental health disorders as a whole, we've seen a shift from biomedical to more of a social model in general, holistic model. So that being said, the social model. So this focuses on societal barriers and biases against people with disabilities rather than on the person themselves. So we're not looking at the disability or the condition or the issue in general. We're looking at more of how that individual fits within their environment and how that can be an issue. Barriers to learning, education, and anything else. So an example would be, I think I mentioned this before, most of us don't have to think about an elevator not being present in the building to get us to our class on the second floor, or the walkway outside being a little off from roots and things like that. So it's very difficult to walk around campus, those kinds of things. So disability is created by society's failure to embrace and accommodate the person. Limitations experienced by people with disabilities are what defines the disability rather than the issue itself. A disability is viewed not as a personal fault based on a medical diagnosis or limitation, but as more of a public concern. And the counseling process falls nicely in line with this model. Like I said earlier, we tend to be more social with the way we view working with our clients as opposed to medical. So the focus is on helping the process of gaining strengths, interests, and abilities of each person, not on the person's diagnosis, weakness, or deficits. So it kind of gets into that positive psychology realm as well. So moving past baseline into resilience, strengths-based, living a more fulfilling life, right? So variations on the social model of disability. So the social model implies that a disability is more than the individual's difference and includes attributes that are outside of the individual, so that's socially or culturally based differences. And disability is highly correlated with low education, poverty, the community setting, the environment, and low resources. So something to keep in mind that those are those environmental factors that are going to affect your clients who have a disability. 25 to 64-year-olds with a severe disability have actually been found to have an increased likelihood of living below the poverty line, having fair to poor health status, receiving public assistance, and having Medicare or Medicaid coverage, and having an annual household income of less than $20,000. So something to keep in mind, your clients who have disabilities are more likely to need you to advocate for them socially, to help them finding resources. And then that comes into play with this idea of they may be less likely to seek out your help to begin with because they don't have the resources or the ability to get to you, that kind of thing. So if they are able to see you, they may not need as much help as the people who are able to see you. So if this is a group that is near to your heart, so you may want to reach out to different facilities to make connections so that these types of clients can seek services from you, if that makes sense. Okay, so we also have the classic model. So this emphasizes the relationship among four main factors, so pathology, impairment, functional limitations, and disability. So the disability process or the pathway to disability starts with pathology or diagnosis. So the individual's diagnosis, disease, injury, condition, or illness. Then we have impairment, so an individual's dysfunction in a specific body system. Then we have functional limitation, so an individual's ability to perform daily life activities like walking, reading, speaking, that kind of thing. And then disability, so an individual's difficulty in doing basic activities, so work, household management, hobbies, social interactions. So this is like a process. Okay, so this model considers risk factors like low socioeconomic status, chronic health conditions, poor health habits, and poor access to healthcare. The model also takes into account extra individual intervention strategies. So this would be like effective medical and rehabilitative care, caregiver support, adaptive assistive devices, social service programs, structural or architectural modifications, things like that. And it also takes into account intra-individual intervention strategies. So this would be like lifestyle and behavior changes, psychological attributes, coping strategies, activity accommodations that might help the individual maintain independence for as long as possible, that kind of stuff. Okay, so counseling individuals with a disability. Something to keep in mind is that, like I mentioned earlier, I touched on this, different societies view people with disabilities and different challenges based on the beliefs and biases of that particular society. So it kind of gives them a different lens. For most of us, that would be the American lens. A more extreme example of the differences between some societies and their view of disabilities would be an example from the textbook. So some Southeast Asian cultures view person with blindness in a more favorable way, and they believe that a blind person possesses a specific and valued insight. On the other hand, a lot of Western societies would view that same individual as someone who has a vision disability and cannot see. So someone with more of a disability uh, pathology, right? So various roles may intersect when counseling individuals with a disability, and this would be the role of the individual. So the role that a person with a disability is expected to have in their community may influence the willingness of the community to integrate that person into their culture. Another thing is conflicts can occur in trying to balance um, the person with the disability's needs and expectations with the concerns of the family and the community against that person's plans and aspirations for life, both now and in the future. So there might be a little bit of conflict there. Another role is the role of the family. So 94% of the world's societies view the extended family as very important. So not just the nuclear family, but extended as well. And extended families tend to influence where a person lives, works, marries, or even seeks health care. So this has a pretty big contrast with the Western culture's view of individualism. So you see that difference as well, and that may come up with your clients. Western view of rehabilitation and counseling might be at odds with individuals from other cultures or societies with regard to the very basics of rights of individuals with disabilities and their specific cultural beliefs. And then the last one is the role of the community. So in the United States, a person with a disability obtaining employment is a primary goal of rehabilitation and rehabilitation counseling. So that's like what the end goal is. That's why they're going through rehabilitation. But in a lot of other cultures, they might consider an individual with a disability engaged in the workforce as more of a sign of neglect. And they may even view it as abusive. So that's something to keep in mind as well. Okay, so a subgroup of clients with a disability who are seeking counseling in greater numbers are combat soldiers and veterans, those with a physical or psychological wound. So you're going to see this a lot more and more, especially if you work in a VA, obviously, but even outside of the VA. I've seen a lot of members of the military outside of the VA system paying privately because they may still be um, active and they don't want a paper trail. So you might see that as well, something to keep in mind, especially like Air Force, if you stay in the area, they may seek out services outside of the military system, if that makes sense. So a unique issue from current day's wars is polytrauma. So combat veterans have higher rates of polytraumas, which is defined as 2 or more permanent injuries to the body that result in physical, cognitive, psychological, or psychosocial impairment and functional disability. So examples could be a major limb loss, bone fractures, traumatic brain injury, visual impairment, hearing loss, and burns. So if you're not familiar with the VA system, um, something that happens when a veteran is diagnosed with a disability through the system is, and this is kind of crazy to think about, but you can see it in their chart, their injuries are literally broken down into like percentages. So it's like what makes up the individual, which is interesting how they view the veterans in that light. So like 10% TBI, traumatic brain injury, 5% hearing loss, 20% bone deterioration, things like that. So they'll break down the individual into percentages, and that's what makes up their disability. And that's kind of basically getting at this idea of polytrauma. Okay, so in addition to polytrauma, combat veterans also often present with post-traumatic stress disorder, so PTSD. And this is a result of their experiences in combat. And in order to get disability through the military system, the PTSD and those other injuries noted on the last slide have to have occurred while on duty. So if they were off duty, they're kind of out of luck. That's something to think about. I also saw a lot of veterans who were hurt during training, so that comes up a lot as well. So, PTSD. Like I've mentioned before, women are more likely to be diagnosed with PTSD because even though they don't experience as many traumatic events, the events they do experience tend to be more traumatic in nature in a way because they're relational, right? So we talked about that. However, you do see a lot of males within the military system. There are more males there. Having diagnosable PTSD because that's more extreme, right? So that military action. All in all, most individuals are resilient, like I've said before, so there's not a diagnosis, but this is a skewed population, right? So, advances in body armor and technology, as well as medical and scientific advances, have led to over 90% of veterans injured surviving with injuries that would have been fatal in previous wars. So they're experiencing these very traumatic events, horrific medical issues from being hurt in the line of duty, and then they're surviving. And then they have to deal with the memories of that kind of thing, when before they probably wouldn't have survived. So that's one of the reasons you see more PTSD nowadays. For every service member killed in war, estimates of 16 wounded veterans will return to the U.S. with some form of a disability. Counselors need to consider the following when counseling veterans. So they may need to change from a we mentality to being in the military, or of being in the military, to more of an I mentality in order to plan and achieve goals. So the military, it trains the soldiers, right? And you might kind of have to help them untrain a lot of this stuff that's been ingrained in them that helps them make it through their military experience. But now they're in day-to-day life outside of the military, and they have to kind of rewire the way they view life, if that makes sense. Cultural background is also an important factor to keep in mind, and service members' strengths and limitations are important to identify in order to overcome barriers. So once again, more of that strengths-based approach that we're seeing a lot in working with individuals. Ableism. So the definition from the textbook is that ableism refers to social attitudes, rehabilitation, and counseling practices and policies that favor individuals who have or are perceived as having full physical and mental health abilities. So this is in contrast with individuals with disabilities who are excluded from social power and full access to services and resources. So when it comes to ableism, language is very important. Language is also always important, but in particular here. So an example would be like changing positive attributes to negative attributes. So we see that a lot. No, let me explain that better. So we see people in day-to-day life stating things that may appear as positive attributes, but are actually kind of negative underneath, like the undertones, if that makes sense. So you hear people talking about individuals with disability quite a bit as brave, right? So that could be construed as the individual actually being weak, right? Courageous, that could be viewed as them being unfortunate and then having to kind of deal with this, and they're so courageous, right? Inspirational, that could be viewed as them being pitied. So being careful with wording here. In defining ableism, there must be a focus on the role of the larger society, including cultural attitudes, beliefs, and perceptions regarding a person's abilities or disabilities. In order to be sensitive to the unique beliefs, needs, and abilities of our clients, we should reach a certain level of awareness, knowledge, and skills. So this is kind of going into what I've harped on already, this idea that we don't want to rely on our clients to always be educating us. We want to come into the counseling relationship with awareness of issues that may arise, as well as knowledge, a basic understanding of various issues, and then going home and doing our research to add to it, and then skills as well. So always honing in on our skills and training and learning from our clients as we go as well. So the first one, awareness. Here, we need to become more aware of ableism and its effects on individuals with disabilities in order to better deliver effective counseling services to them. So it all starts with awareness. Also, becoming social advocates for our clients, getting more directly involved in helping our clients overcome barriers in order to help our society be more inclusive. The next one is knowledge. So, the population of individuals with a disability is probably one of our country's largest minority groups, and there's a long history here of disability policy and legislation. So, the view of disability in the United States started off more as treating it as a military matter and the unfortunate outcome of an individual's patriotic service. This kind of shifted into being the unintended consequence of the Industrial Revolution. Then it shifted more to promoting it as a societal cause for charitable treatment, and then considering it as an indication of membership in a minority group with a push for empowerment and equal rights. So we've seen this shift over time. The next one is skills. So fully and continually assessing both the client's feelings about their experiences with having a disability, as well as your own understanding of those experiences. So checking in a lot, which is another thing that I'll harp on throughout the quarter. Most clients with a disability may view their disability as a basic and valued part of their identity. So that in actuality, they discern positive aspects of the disability rather than negative ones. So that's something else to keep in mind as well, and to help them continue that view and maybe help other clients who are having a hard time view some of the positive aspects. So that meaning making that we've talked about before. Believe that the client with a disability is a person first who also happens to have a disability. And this comes up a lot with labeling in general your clients. So another reason why we want to be careful with our language. So, I cringe all the time. I hear people say that bipolar patient or the borderline, right? That kind of thing. So we want to be really careful because the more we say those things, the person becomes their label. We can't help but start to view them that way. And you hear the patient do that as a lot as well, and they view themselves as their label. So being careful with labeling, with our language, and viewing our clients as being people first, right? It seems obvious, but we all kind of fall into that trap sometimes. Try to minimize the power differential between you and your client. It's impossible to completely get rid of it because, they're coming to us for help. We are the expert. But try as much as you can. And this really comes from that feminist theory that we talked about before as well. Create effective change within local, regional, state, and national policies and systems. Contribute to research efforts. Advocate to promote the rights of clients and change the system on behalf of the client's needs. Be competent and obtain appropriate training. Be knowledgeable about various topics related to disability issues. Establish professional relationships with agencies that serve people with disabilities as well, if you can. Okay, so we have disability affirmative counseling, DAT. So this is a theory that you can use with your clients. So here, we're extending from the social model and viewing individuals with disabilities with value and worth rather than being deviant or pathological. So this considers the multisystemic implications of having a disability. So examples here would be like the political, legal, economic, and educational implications. And it's not just limited to the personal impact on the client with a disability. So it's kind of an extension there. Counselors practicing DAT deal with complex intersections of disability with gender, race, religion, sexual orientation, and other complex human characteristics. So once again, we see that intersectionality. So we each have our own unique profile, right? DAT helps clients take responsibility for their disability, manage and prevent the internalization of negative reactions, and feel important connections with peers and family members. Also talk openly with clients about disabilities, locate information about specific disabilities, pursue reasonable and accessible accommodations, and refer clients to relevant support groups. So building up your resource book, right? so that you have resources to give to your clients. Age demographics. So by the year 2030, 20% of the population will be comprised of older adults. 45 million Americans are 65 years of age and over. In the 1900s, the average person could expect to live to about 47 years. And in 2015, the average person in the US could expect to live 76-ish years if they're male, 81-ish years for female. And this is all races combined. So over 3 in 5 people in this group are female. We do see females living longer for various reasons, one of them being that they're less likely to take risks. So a lot of males you see in like adolescence around 13 years of age, when puberty hits, higher rates of deaths. So that's when risky behaviors tend to begin. They also tend to have jobs that put them at higher risk for being injured, stress on the body, that kind of thing. But yeah, all in all, we see females live longer than males. Over the next 40 to 50 years, the number of people over 65 is expected to double, and the number of people over 85 is expected to triple. Minority populations are also living longer and getting older, so U.S. senior citizens as a group are becoming more racially diverse over time. The biggest change by the turn of the 22nd century is expected to be in the number of older men. So we're expecting to see a shift there. Baby boomers. So this refers to individuals who were born between the years of 1946 and 1964. The advancing age of the baby boomers, increased life expectancy of older adults, and increased racial and ethnic diversity of older adults will put more emphasis on social policies that directly benefit older adults. So counselors must be ready to assess and treat aging-related issues in an effective and competent way. So you are more likely to have a client who is a part of the geriatric population. So being prepared for that and knowing some of the issues that may arise and how to advocate for them and give them resources. So ageism, this is the assumption that chronological age is the main determinant of human characteristics and that one age is better than another. So this is a form of discrimination against those groups with higher vulnerability and less access to resources and power. So children, youth, seniors, and elders are most marginalized populations in our society. So most people don't think about the opposite side of that spectrum, the children and the youth. They also may experience discrimination and ageism. Cultural attitudes are evidenced in media, social policy, and legislation. So promoting that stereotype that our society places on remaining youthful, healthy, beautiful, and successful, right? Adultism. So this is discrimination against young people and children. The belief that youth and children are ignorant and untrustworthy, unpredictable, and have nothing to contribute to their own well-being or society. So adults believe that they can and should exert control over young people and orchestrate their lives, tell them what to do, and this creates a sense of oppression and disempowerment among young people. So I know a lot of my students want to work with adolescents, so that's something that might come up a little bit in session. Okay. Older Americans have distinct psychological and physical issues that are associated with aging, and this might result in experiences with ageism. So physical changes include changes in skin, so like wrinkles, less elasticity, changes in hair, it may thin, turn gray or white, changes in one's voice, so it may become softer and weaker over time, changes in height, we might become a little shorter, changes in mobility, so a slower gait, we might be a little more off balance as we age. We also see age-related medical or health conditions such as cancer, cardiovascular disease, arthritis, and osteoporosis, and this is especially among women. And then 88% of people over age 65 years have at least one chronic health condition. So a huge thing to keep in mind when it comes to working with geriatric populations is they were once young and they remember that for the most part. And they've felt their body change and they're still with it cognitively, and yet they can't do the things that they could do before, and that's really, really frustrating. So you're going to see that a lot. We also see psychological concerns, and this includes physical changes affecting one's self-concept. So reduced independence and ability to take care of themselves, which is kind of what I just touched on. We see dementia. Almost 10% of people older than 65 years develop dementia. And this has a risk of doubling about every 5 years. So remember, dementia is a symptom, not the disorder. So dementia would be a symptom of Alzheimer's or Lewy body disease or things like that. Loss of a spouse, family member, and aging friends. So in older adults, the experience of loss and grief may be prolonged and frequent, and it may have a greater impact as they realize the finality of their own life. So seeing, we can think of Erickson's life stages, right? So of development. So looking back on their life, knowing that they may be near the end of their life, reflection, you might have some of that kind of thing coming up in therapy, right? So existential therapy, that kind of stuff. That's the word I was looking for. Socioeconomic and employment issues are also relevant. So in the United States and most Western societies, the view of older people is generally that they have, based on their function of their role in the economy. 13% of older adults live below the poverty level, compared with 14.8% of younger people. So we see more older adults outliving their occupation, I suppose you could say. So being either pushed into retirement or having to retire, but then living longer and not having the funds to survive, being on a fixed income, that kind of thing. Social Security Administration's definition of retirement age has been extended from the traditional or normal age of retirement, which was 65 years, to the current age of retirement, which is 67 years for all people born after 1959. So we're seeing the age of retirement being extended. Age discrimination or denying a job or promotion to an individual solely on the basis of age is illegal in the United States. So that might come up with your clients, and you might need to advocate for them and give them some resources and knowledge about the laws. And U.S. Age Discrimination in Employment Act of 1986 protects workers over the age of 40 years old. The Older Americans Act amendments of 2006 protects the rights of older people who, under this act, are entitled to adequate retirement income in accordance with the American standard of living, the best physical and mental health which science can make available without regard to their economic status. They should be able to obtain and maintain suitable housing, independently selected, so they should have a say, designed and located with reference to any special needs they may have. They're entitled to full restorative services for those who need institutional care. The opportunity for employment without discriminatory personnel practices, and they should be allowed to retire in health, honor, and dignity after the years they've contributed to our society and the economy. They should be able to participate in civic, cultural, educational, and training and recreational opportunities, have efficient community services such as low-cost transportation, the immediate benefit from research that offers knowledge about health and happiness, and freedom, independence, and individual initiative for them to plan and manage their own lives. So aging individuals are accustomed to being independent. They've lived a full life. They have lots of experience. They've done countless things and had different roles and jobs and in their family. So these are all things that we need to keep in mind. The counselor's role is to facilitate guiding the older client in making informed decisions and showing respect for their years of life experiences, their knowledge, and the expectations that form their individual decisions. So we have gerontological counselors, and these are counselors who specialize in working with aging and older clients. And that's its own kind of niche within counseling. So they provide counseling services to elderly clients and their families when they're faced with changing lifestyles and roles as they're aging. Although most citizens that are age 65 and older don't have a disability, they are at an increased risk of developing one. So it's important that we consider a relational perspective. So this is the view that aging and disability is a process and a dynamic interaction occurs between them within the cultural norms and our socioeconomic status. So with that, we have awareness again, knowledge, skills, and then successful aging. So awareness, counselors should be aware of their attitudes towards individuals of various age groups. Ageism may be manifested in the following ways. So we might have assumptions of limitations on behavior due to youth or aging, positive or negative stereotypes about younger or older persons, the belief that children and youth are not as competent and must be directed, so that's that adultism we talked about, the belief that older people have been socialized to handle their own problems, and the belief that one's mental health needs decrease with age. Then we have knowledge. So counselors do adhere to the ACA gerontological competencies, which came out in 1990, as well as the CACREP standards. Counselors interested in working with this population might also want to navigate and investigate any available professional and community resources available to them. And then skills. So counselors should help clients to build resiliency on the positive aspects of aging. Clients can understand aging is inevitable and we can be successful in the outcome. And then successful aging. So this is the avoidance of disease and disability, the maintenance of cognitive and physical function, and sustained engagement with life. So that's aspirational to assume that people have resources to live a healthy life, adequate access to healthcare, a safe living environment, and the ability to make their own decisions. So successful aging may be better defined by the person living the process. So each individual is going to have a different process for themselves, and they should be able to define it for themselves, if that makes sense. So that is the end of Chapter 8, Disability, Ableism, and Ageism.